one topic that we haven't discussed, and there are some interesting study here and there over the IMS, and I think at ASH we will see much more, is the precursor condition. So we discuss about MRD, we discuss about genomics across all the different states and therapy-related tumors as a complication. I think the precursors is really a kind of the place where we should move the fight, meaning doesn't mean that we need to treat all the smoldering, because that would be crazy and probably unethical, but we should need to treat or think about following these patients in a different way. So smoldering and MGUS are really phenomenal concept, and the myeloma community with Bob Kyle and others developed this concept like 20, 30 years before anyone else. Like the clonal hematopoiesis for leukemias and MDS is kind of less than 10 years old. And the concept of MGUS is 60 years old almost. So we really have this classification that helped us a lot to understand the disease. But we're still using the same classification developed in 1980. So now the classification is 42 years old and is based on 10%. And all the prognostic factors that kind of are used to predict the risk of progression and are used to develop clinical trials for early interventions are based on surrogate of the disease burden. And so we show in our work, and other people are confirming it, and we are expanding it, that there is really a dichotomy among precursor conditions. So there is a kind of three groups. One are myeloma already. They are asymptomatic. They don't have symptoms, but they are already myeloma. You can see all the alteration, genomic alteration, microenvironmental alteration, immune alteration that are in the myeloma patient. And so the question is, what do we do with these patients? And most of these patients are within the criteria. So the trials that use the Mayo Clinic, the Spanish or the EMW are most of those patients probably have these kind of genomic features. And then there is a second group that are the myeloma 2B, or what we call myeloma 2B in a like kind of friendly way, that is patients that will likely or most likely develop a tumors, but it's going to take some time. So what are you going to do with those? Of course, we cannot treat them with transplant or CAR T because they are like kind of toxic treatment, right? And we don't have a magic wand to just clear the marrow. So we need to think strategies to kind of probably playing with the immune system, with the diet, vaccine, things that approach that doesn't affect the patient life or quality of life. They don't put any threat of complication, but they might have a huge benefit in delaying the progression. And then there is a group of patients that is just like a benign condition. Of course, a benign condition can turn in malignant, but that takes many, many years. And so that's where the field is going. I saw some interesting study at IMS, interesting study we presented at ASH. And I think that's very, very exciting because it kind of like we are living after 42 years, we are on the edge of changing this classification, of kind of proposing new concept. And that's, I think it's very interesting for scientists, for clinicians, and also for patients, because this condition affects almost more than 5% of the population above 60 years old. So it's pretty common, in particular if you test with the more advanced technology, like mass spec or compared to the standard electrophoresis. So I think it's a pretty exciting time. There is a lot of work to do, and also a lot of, we need also to avoid to rush and develop treatment for smoldering patient that is kind of completely different compared to the myeloma. If we think that these are myeloma, we should treat them as a myeloma. If we think they are a myeloma 2B, we should think about something else. But I think the integration of clinical trial, genomics, and functional model, it will be very helpful to develop the right idea, the right classification model, and to design the right clinical trial to answer the right questions.